Good afternoon, everyone. We're just we got a few more people hanging out in the waiting room. We're gonna let in. Just give us a few minutes. We've got 12 o'clock bunch here. This is the last day of our series for you hardworking community health center folks out there. We're going to spend some time today talking a little bit about how to best use psychiatric expertise. And I want to save some time for questions at the end about anything. You can talk about anything you want. Short of Amelia pitching me some hard cases, we might not talk about that. Some time to just answer questions about some of the things we've been through, and also the Mental Health Technology Transfer Center, who's been sponsoring this for you guys, wants you to do a survey. So we'll save about 5 minutes at the end for you guys to do that. I don't know how that works, but Stephanie will work her magic on doing that for us. So let me just give it a couple more minutes and then we'll get started. Hang on, finish your lunch. We'll get started in just a sec. All right, 12:03. Let's get going. So welcome again. I'm Lori Raney. I've been, I think I recognize everybody on the screen at this point. We've been doing a 7-part series on a number of things that affect those of you working in FQHCs, community health centers across North Carolina, kind of picking up on some themes that you guys identified in a short questionnaire whenever we were getting folks to sign up for this, to give us their thoughts. So we have gone through a series of things from practical direct line interventions, the ways to think about patients, and some of the many things they're going through. We know our patient population in community health centers is a safety net population. We know their mental health issues are significant, and that you have really become the hub for mental health expertise and mental health treatment. And that has a lot to do with sort of the failure of our mental health center to really have adequate resources for patients. And so primary care, and in particular, the work that you're doing has really had to pick up and take over where a functioning mental health center should give us a little more support. So I really applaud all the hard work you guys are doing, and hopefully some of the things we have been through have been helpful. And if there are other things that you might want to look at down the road, because your North Carolina Mental Health Association with Justin at the helm has really been really helped us identify and help you do your job as well as you can, given the burden of the work. And me working in an FQHC myself, we see this work every day. I know that it's tricky for you, and just really applaud what you're doing. Today, what we want to talk about is, what do you do if you don't have a psychiatrist or a psychiatric nurse practitioner? What do you do if you get one? What do you do with them? Or if you do have one and their wait list is 2 to 3 months, how might you think differently about the work that they're doing? Because, I think you guys have kind of figured out, because you're clever people who work in the trenches, that there are not enough psychiatric clinicians out there to meet the mental health need that we have across the country, across North Carolina, in more rural areas. I'm out in Western North Carolina with a few of you. Some of you are on the eastern side of the state. Some of you, there's a little more in the middle, but if you really look at the distribution of psychiatrists in North Carolina, there's really the distribution around East Carolina, Duke, Chapel Hill, Charlotte, the bigger towns, Winston-Salem. Those are the kinds of places where we see a lot of psychiatrists, not necessarily providing care or in your federally qualified health centers, maybe out in private practice, maybe for private organizations or big health systems. But for those of us in particular out in rural areas, there's quite the shortage, and we need to get clever about what we're going to do. I'd be curious, any of you in the chat box, you can either say, have a psychiatrist, don't have a psychiatrist, looking for one, whatever that looks like. But if you guys could kind of give me a little bit of a sense too, in the chat box of what you currently have, what you might be looking for, and then, if there's any issues around it, that would be, nope, don't have one, looking for. Okay, I haven't seen anyone yet that has one. So this I think is a timely conversation. And for, Krista and Kurt, who are looking for one, and Sarah, I want you to think, if you get one, think about what you hear today, because when they come on board, you need to really think about, how am I going to use that person differently? Because I will tell you, if you bring on a psychiatric provider, either a nurse practitioner or a psychiatrist, and you plug them in to provide psychiatric time like they do anywhere else, like they would do in a private office, 1 hour intakes, 30-minute follow-ups. If you bring in a psychiatrist, and Tammy, I'd be interested at some point in your experience of this, if you bring them in and plug them in and they do the same thing that they always do, that they've been trained to do, you may end up with a waiting list. And Tammy, I'd be curious whether or not you end up with a 1, 2, 3 month waiting list. And I'm actually going to show you some data from an FQHC that had a waiting list of, 300 patients. It was a huge FQHC. And how do you think about thinking about your psychiatrist differently? Okay. This is what we want to talk about today. So let me get started. What you need to kind of think about when it comes to psychiatric time is there's 2 ways you can do this. Remember, I just said, if you bring them in and they see one patient at a time, that's called direct consultation. So that can be in person. That can be if you guys have telepsychiatry. But that's what we mean about direct. I'm gonna evaluate you by yourself, one-on-one in the office. If we do it, you can develop, you got to be careful. You can certainly develop a waiting list. And, we just any of your psychiatrists actually do telepsychiatry, or if they come on site. But we're going to talk more about indirect. What happens if your psychiatrist doesn't see the patient? Now, I am going to touch a little bit on direct to talk about one particular model, and hopefully some of you are doing this. But for the most part today, we're going to talk about indirect consultation, because that's really the future of psychiatry. And in our program at AHEC, that's actually how I am training a number of our psychiatrists. Tammy's a recipient of that. Ted Hughes and his team are about to be the recipient of a form of that. Those are just the folks out in Western North Carolina I'm working with, where we really are thinking about this direct and indirect, and how do you provide the most care? Remember, the most care from the smallest resource you have. So what we want to get is as much care to as many people in need as we can, and that means we have to think outside the box. So I'm going to show you all the different ways outside of the box people have been thinking about. This is a paper that I published back in 2020. And basically what I tried to do was go through every sort of ways that a psychiatrist can help a system providing care to a patient. These are, patients that need psychiatric input. What are all the different ways we can do it? And the first one, because I don't have any slides on this, but a lot of us, go and say, hey, let's just give our PCPs a talk on depression and they'll do a better job. I know many of you are working with depression screening and follow-up quality metric. You're working on depression remission 12 months quality metric, and you're probably not hitting those or even close to hitting those quality metrics. So we say, let's just go out and get someone to come in here and talk to our PCPs, do a training, everything will be fine. And it doesn't really do that. The research shows maybe for a month, they change their prescribing practices a little bit, but in the long run, it doesn't work. So doing didactic presentations, it's a good thing, but you need more than just that. And I'm going to show you a little bit of examples about more than just that. And then the other thing I want to mention is about the consults. And if you bring in a psychiatrist, because all of you are looking for one, and Tammy, I'd be curious what you're doing with your 2 part-time ones, but there's this consultation called one and done. It could actually have a little tweak to it, is that you let patients know, and you let the primary care providers know, we got a little bit of psychiatric time. We got 2 to 4 hours a week, teeny tiny. And that psychiatrist is not going to build a big old caseload of patients. They're going to, and there's a program in Charlotte that I worked with. You got one consultation with the psychiatrist, one. They wrote a very detailed note, lots of scenarios. Back the patient goes to the PCP, read that note and do what it says. Call me if you need me, but that's all I'm going to do. I'm not going to write the prescriptions. I'm not going to see the patient back. One and done. Another tweak to that is, okay, the psychiatrist will see them for an evaluation, either send them back, or if there's some complexity, maybe see them for 2 or 3 appointments and then send them back. So for those of you that are looking for a psychiatrist, I would say if you get one, you prep the psychiatrist, you prep the PCP for this, and you prep the patient, okay? This is a really nice way to use limited time, get your PCPs prescribing and understanding and reading the psychiatrist's note and actually learning as they read the note, follow along with the patient, actually learning how to do more of the care themselves, because these indirect ways of doing care actually help train the psychiatrist much better than those didactic presentations, because they get to see the note from the psychiatrist, what they did, what they recommend, and they start going, aha, and apply that to maybe to the next patient or the next patient, something they learned in that consultation and the work that the psychiatrist did. Otherwise, if the psychiatrist is just seeing them one-on-one, they rarely ever see their note, maybe see their meds, and they don't have to worry about it because the psychiatrist is doing everything. When you put your psychiatrist in a consultation or 1 or 2 visit, 3 visit max situation, get that patient back to them, then it actually gives your primary care providers an opportunity to learn. And the more they learn how to do this work, your primary care providers are already pretty savvy about prescribing antidepressants like SSRIs. That is something they've been doing. They don't shy away from it, but you get a little more complicated than that, or they get stuck because the patient's tried 2 or 3 and they don't know where to go from there. Then they really need that help and that knowledge about what to do next. And what that's called, as the psychiatrist is sitting in the background, giving them some information, showing them how they manage a patient, that's actually called case-based learning. And that's how we learn. That's how people learn. I always say the worst way to learn something is to sit with someone with a bunch of slides and do a presentation, which is exactly what we're doing today. But if you were a clinician doing some specific stuff, and if you guys remember back on some of our earlier stuff, we did review cases, because that really is the best way for medical folks to learn. And that's what happens with these consultations. So on the rest of these things, let me just go down, because some of them I'm going to show you separate slides. Case reviews with the team. Amelia can tell you this is something I've been doing with NCHP for a while. And what we tend to do with those case reviews is we discuss the most difficult patients. So we only have time for Amelia, maybe 2, 3, 4 patients in that hour we have, and we talk about the trickiest patients, the ones that are having the most difficulty. It's not a lot of patients, but at least helps the PCP with some that are more difficult. And in our call last week, we were able to talk about several different things, including a 5-year-old. So it was a really nice talking about complex patients. The other one I want to point out down here is asynchronous consults. And this doesn't really, well, what you do is like a social worker, psychologist interviews the patient on film and then sends that film off to a psychiatrist who looks at the film and then sends back, or video, I think I'm dating myself with film, looks at the video and makes some recommendations for the PCP. To me, that's pretty time consuming. It's asynchronous. It's not quite a direct, and someone else is interviewing the patient, but they send back some recommendations. I'm not a huge fan of that, but like UC Davis out in California, they're doing a lot of research around this. So it could be promising, but it doesn't, it like gives you somewhere to send off your, videos. But in my mind, it just doesn't, it's still kind of limited because it's still one patient at a time, right? And so you got someone doing the videos, someone reviewing the videos, someone sending back. And it's just, to me, it's pretty time consuming, and I'm not quite sure it meets the needs that you guys, might want. At the very bottom is seeing patients directly. So we've gone from didactics, which is simple, trying to train the PCPs, all the way across now to let's just see all the patients, telepsychiatry, or right in your clinic. So as you can see, we have kind of this broad range of what we do. This is another paper that I wrote a while back, where this is kind of what we need to be thinking about in primary care. And I on the very right-hand side is telepsychiatry. So we're not going, that's that direct evaluation I was talking about. So we're not going to talk about that. On the left-hand side, one of the things to think about is what are all those patient-facing things? I mean, your patients are downloading apps, good, harmful or not, helpful or not, in order to kind of help them self-manage. In the middle are these things that I want to talk a little bit more about: eConsult, Project Echo, and then collaborative care. Those are the big three where we begin to leverage your psychiatrist differently, right? Not see patients directly, but stand behind and support you and the primary care providers. And again, Amelia has, and her team at NCCHCA, they have direct examples of that. We're talking about difficult cases, and I'm writing notes in their electronic health record to their PCP, or their PCPs. It's absolutely amazing. Actually come to our Thursday meeting. So we really do have that time for that interaction. So let's go through a few of these in a little more detail. Again, because at the end of this, we really do want to leave time. I want to hear, I see that most everyone's trying to get one, looking for a psychiatrist, and Tammy has two. And I want to be able to get to Tammy's experience with hers, but also for those of you that are looking for one, what do you think about some of these? Building their capacity, the psychiatrist standing behind the PCP and helping them do this work. Because I'm sure you have questions like, well, how do you pay for it, and this, that, and the other. Okay, so let's start with eConsult. eConsult is your primary care providers who are seeing patients are stuck. They're not sure what to do, and they use a platform. A lot of people are now starting to actually use electronic health record, but they actually use a platform and they have these psychiatrists sitting there waiting, ready to go, who are able to answer questions quickly. On an eConsult platform, the PCP might send their note, their last visit note, they might send a med sheet, because these companies tend to be all around the country. They're not hanging out there in your clinic or have access to your electronic health record. So the PCP has to send them the meds, send them the note, send them the what is it that you want to know. And then the psychiatrist sitting wherever they are, California, Wyoming, Raleigh, whatever it is, sends back, here's what I recommend. Here's an article on it. Here's an algorithm you could use. Here's a website with information, and they send back the information. So there's 5 or 6 companies involved in this. I don't know if any of you guys have tried contracting with an e-consult. There's Rubicon, and I don't even know what the rest of them are. There's like 5 or 6 out there now. And a lot of big health centers are using this. And for those of you with a part-time psychiatrist, it could also be, something potentially you could send them a message through Epic or through whatever. And the psychiatrist can get 10 of these messages and in an hour, send back 10 short consult notes. Amelia knows how short our notes are. We're to the point. Can send back those notes on those 10 patients. And all of a sudden, in an hour, your psychiatrist has helped 10 people instead of the one they would normally see during that psychiatric intake. So with the e-consult, it can either be, a commercial platform. And like I said, there's all kinds of people out there. They charge you like $5 a consult or 15 or something. I can't keep it all straight. And there is some payment. There are some CPT codes for that. So that is one approach that we are seeing more and more sites use just to help the PCPs and get that information back. Okay. The second is Project Echo. How many of you have been involved in a Project Echo? They were and have been for the last 10 years, have really been a big source of, it started with Hep C. They've done some mental health ones. They've done epilepsy. They've done especially SUD with OUD. Any of you, North Carolina, you ever participated? There's been Project Echoes for integrated care. Anybody ever done Project Echo? The way it works is you have a number of primary care clinics, maybe 3, maybe 10. And those, let me show you a picture of it. So on the right-hand side here would be all of you. You guys would all be sitting here on video and in a hub somewhere at Mayheck, somewhere in Duke, Chapel Hill, ECU, wherever it is. In this hub are the psychiatrists, social workers, peer supports, nurses, whoever is, whatever the diagnosis, whatever the condition is, folks are sitting in this hub. All of you are on video, and we're talking about patients. So there's a component to it. The first 20 minutes is usually didactic, and the next 40 minutes is all of these sites pitching their cases. And again, kind of like we're doing with MCHP, sometimes it's their more difficult patients. But what happens when you're all here together and you're talking about patients, that's that magic I talked about earlier. Everyone begins to learn from everyone else. When PCA Espanola presents a case, Las Vegas hears about it, Memorial hears about it. And these guys begin to form actually a community of folks all slogging through the same thing, and begin to help each other and learn from each other and learn from the cases. In this hub, this is where the action is. This is where the experts are sitting. And usually you can't do about more than 8 or 10 of these because it gets to be too busy. One of the really cool ones I heard about that University of New Mexico did is they're doing a Project Echo within the prison system. So they have in each prison one identified kind of peer support person. Their job is helping new inmates make it through, trying to kind of limit the mental health and stress and issues that happen. And it's so cool because this is the one I watched. You have all these peer support people sitting there in their jumpsuits and their striped jumpsuits or whatever's that prison's uniform. And they're all talking to a hub of folks who've worked in correctional medicine, correctional mental health, talking about patients, getting support and getting education around the work they do. Way cool. So Project Echo started for Hep C and alcohol use and opioid use disorder. And they are into all kinds of pediatric stuff. And they can do, like I put over here, depression, anxiety, substance use, child conditions, all kinds of cool stuff. And so here's just an example out at OHSU, just this, remember I said 20 to 30 minutes of didactic followed by that discussion. Okay, so I just think it's a pretty cool model. It usually lasts 12 or so weeks. And then it's done. So this is not like your PCPs have to go through it the whole time. The hardest part about it is helping busy PCPs. Here's the pharmacologic considerations in the treatment of adult ADHD. I don't know about you guys, but we are being inundated right now with adults coming in saying they have ADHD. They took the ADHD test online and boy, do they have ADHD. And we're being inundated with that. Well, what if you could have an echo or any kind of, just didactic or thoughts about this. And then you had 10 other clinics saying, yep, that's happening to us. This is how we're handling. We wrote up this policy. We did this, we did that. I can tell you what Mayheg did because we were totally inundated and still are, because people during COVID, they had lots of time on their hands and a lot of people think they have ADHD, adults. So it's been quite the thing. So what they did during these echoes is, that first part, whoops, they're sitting here, 20, 30 minutes of didactics, and then, which is this, and then talking about cases. So they could sit here and all these folks are talking about adult ADHD, learning from each other and learning from the experts in the hub and able to ask questions. Look, I tried Adderall, I tried Vyvanse, I tried this, I tried that. What do I do next? Or I don't know if this person has ADHD or not, but what should I do? How do I think about it? They smoke pot all day long. How do I know if they have ADHD or not? So that's just the beauty of the hub and the didactics. The other thing is for getting information, and I'd be really curious for you guys, is these child psychiatry access lines. They are all across the country right now. They even have the national network of child psychiatry access programs. Child psychiatrists immediately available by phone. Usually you call in, you get the person, the behavioral health person that's monitoring the line, and they say you can talk to a psychiatrist within 30 minutes. So the primary care providers have all this access. Kids are being discharged to primary care from inpatient site, and they come out on these amazing cocktails of medicines that child psychiatrists at Copestone, which is our local adolescent inpatient unit, think are necessary. Out to primary care, they go on a cocktail, and the PCP goes, I do not know what to do with this. I've never heard of half of these medicines. So it's a really nice way to get within 30 minutes or less a phone call. So this is not an e-consult. This is not a Project Echo. This is PCP to child psychiatrists. They have seven child psychiatrists. They have half-day blocks, and the PCPs can call in. There's some helping with resources, education support. Some of the across the country, some of them do direct evaluations, but for those of you used to ours, now remember, North Carolina, we have one, yay, NCPAL. One number you can call, press 1 for child, press 2 actually for what's called NC Matters, which is our perinatal psychiatry, but for, so we actually have a couple things available to your clinics in North Carolina right now. So you can call this line, that 919 number, someone will answer the phone, and they will be able to talk to your primary care provider. It provides that consultation. The other thing that many of these lines do, kind of like Project Echo, is they provide education. So if your primary care providers wanted to do a lunch and learn about child ADHD or child eating disorders or whatever, child epilepsy, child depression, whatever it is, these child psychiatrists can actually beam in and do a lunch and learn. If you're close enough, they'll actually come out in your clinic, but they can do education. This particular program is also offering an intensive, it's called REACH training. I forgot what REACH stands for, but somewhere in there, it's about kids. Maybe that's the C. But it is an intensive 2-day course of diagnosis and psychopharmacology for kids, followed by, because remember, I already told you didactics alone aren't that useful, followed by every other week, 6 sessions of that case-based learning. So it's kind of like Project Echo, except they peel out the didactics. You do that intensive. I'm trying to get one of those intensives set up in Asheville, but they're also virtual, and you can even do them hybrid. So there's plenty of ways for your primary care providers to do this training. If you go to the NCPAL website down here, they actually have a list of all the trainings. So, and it's free. So your child family medicine pediatricians right now can go do this training. You can set up a lunch and learn on some topic for your staff. If you're in Western North Carolina with me, I'll help you get started because I'm kind of running that hub out here. So it's a really nice way to get education, talk to a child psychiatrist, help with some coordination. So you can call in and say, hey, I'm looking for an eating disorder program. Where is it? And we have, lists of the behavioral health people answering the phone and going through the lists and saying, well, here's where it is for your area. And so really having a nice resource lists really helping with that coordination. Our child psychiatrists are not doing, one-time direct evaluations of kids. We see that in some other states. But for us, we are at least helping to coordinate and get those resources. Are you guys familiar with, what is it, NC360? It's so it's kind of this care coordination package. The goal is, as we get these resources, to actually get it into NC360 too. We want every place we can for you guys to know, where is there a therapist that knows CBT in the outreaches of North Carolina. Maybe they have to drive to Asheville, but maybe we find one and it's on that resource list. So in your clinics, guys, make sure 919-681-2909 is prominently listed for your family medicine and pediatric staff. We've been going out and putting flyers in all of these offices. Some of you may have the little blue men, the little squishy cell phone holder, and passing out that pins, anything we can with that number on them. So please make sure for child psychiatry and for perinatal. So you press 1 for child, 2 for perinatal. We can help with perinatal a perinatal psychiatrist actually calls back your usually a family medicine person, maybe it could be your OBGYN, and is able to answer that psychiatric questions. You got patients with bipolar disorder, schizophrenia, all kinds of stuff coming in. And to have that access to perinatal psychiatry and child psychiatry is pretty cool. 1 phone number. If anybody has used that or has heard of your primary care provider using that, I'd love to hear about it. Okay, now the other way, we've talked about eConsult, we've talked about child psychiatry access lines, we've talked about Project Echo. Another way to use psychiatric expertise without the psychiatrist seeing the patient and being able to see a lot of patients is the collaborative care model. And I'm assuming many of you have heard of this because NC Medicaid has done a big push around collaborative care. So in this, I'm sitting in the background. I'm getting ready to start the program out at Winches with Ted and Amy. So I'm sitting in the background. The care manager, that's Ted and Amy's position, is dealing directly with the patient and the medical provider, and they're doing the intake. They're doing brief interventions like behavioral activation, some of the things we talked about a couple of weeks ago. And they're meeting with me once a week. And what I do once a week is this care manager has, 40, 50, 60, 80 patients, depends on how ill the patients are, how many they can carry, but usually it's 60 to 80 patients. And we are talking about who we need to talk about that week. We can't talk about 60 to 80 and a bunch of people are getting better and about to get discharged anyway, but we actually use this list on a registry, and North Carolina is giving out these free registries to your clinics that want to do this. Sometimes they cost, sometimes you can build them in Epic for those of you who have Epic. One of our clinics, Winches, is actually building their own registry in Epic. And we talk about new patients, hotspots, people who aren't getting better. And I'm able in that 1 hour with that care manager, Hot Springs, Winches, just Blue Ridge, within Mayheck. We are really doing this in quite a few places right now, and it allows me to take my expertise and 60 to 80 patients here, 60 to 80 patients on another caseload, 60 to 80 or another, and do the math. All of a sudden, I am helping oversee with the primary care provider and you a whole lot of patients. So that's just a model that's, really, again, I'm a consultant. I'm not seeing the patient. I sometimes communicate, or your PCP is more than welcome to call me. I'm sending them notes saying, hey, this is what I recommend. A lot of the work though is going over here in this person, and this is the person you would need in your clinic, and then you hire this out separately. Okay, again, this is how we leverage the expertise. We can do it all virtually, and this happened during COVID. You know, here's your PCP, here's your patient. You got, you know, you guys, you've done a lot of your behavioral health providers, psychiatric consultants, everyone's virtual. So it can all be done virtual. And for multiple small clinics, you can have like one care manager and a psychiatric consultant with multiple clinics. You're too small. You may be too small to have your own care manager to hire someone full-time, but 3 or 4 or 2 clinics get together and share a care manager and share a psychiatric consultant. Now we can really spread this out to small rural practices. All right, so what is the psychiatrist doing? We're doing a couple things. One is I'll answer the phone. Your PCPs call me and we're in a collaborative care, or we're in Project Echo, or we're in eConsult, or we're in something. Is that prompt consultation? You're in NCPAL. Prompt consultation, pick up the phone, talk to you. What are you going to ask about? Diagnosis, what meds to use, what else should I do? PCPs have all kinds of questions. And talk about complex patients. Maybe, you know, again, your patient's pregnant, your kid just got out of a psych hospital on a cocktail, whatever that looks like. And then in collaborative care, and we do that weekly caseload review. In Echo, we have that weekly time where the PCPs can actually talk about their complex patients and people they need help with. So this is what we're doing behind the scenes. And you can see, this is what I was talking about before. I have 4 clinics that I work with. If each of those clinics has, let's just say 50 patients, and I'm working for each clinic 2 hours a week, all of a sudden, 4 times 50 is 200 patients. So in the course of a week, and I'm doing this right now, almost to that point, we have a few, 2 new clinics coming on board. I'll be covering 200 to 250 patients, overseeing their psychiatric care, helping you and the PCP do this without ever seeing the patient. 200 patients. Now imagine how long and how many psychiatrists you would need in your organization to see 200 patients. Way cool. Again, across all these models, you're leveraging the psychiatrist in a different way. And here's that study I was telling you guys about earlier. Here's an FQHC that said, oh my gosh, we have 350 people with this huge waiting list. They were a very big clinic. We're going to get a psychiatrist to come and help. So they got a psychiatrist like many of you have, and the wait list fell a little bit, but not as fast as they wanted it to, right? Because the psychiatrist starts to build a caseload. That's what we don't want to do. All the way back from the beginning when I talked about 1 and done, or maybe 2 or 3 visits, we don't want to do this. This does not result in a huge difference. So it kind of got stuck. And then they said, all right, well, let's do e-consults. Let's do some education of the PCP. So that helped a little, drop that waiting list down a little, but then it kind of, you know, keeps hovering. We still can't knock out that waiting list. Then they said, well, let's try collaborative care. Got the psychiatrist available by phone. We're going to review that wait list. We're going to do this model that you guys know, state Medicaid. And what they had, was a dramatic drop down to the point they didn't have much of a caseload left. All right. So this is a cool study because you can see the strategies we talked about today and the power of them, you know, as you're trying to figure out what to do. Okay. This is just a lovely example of how you can leverage, how much it can do, and how you might want to think about your program. The psychiatrists know they're not seeing the patient. Sometimes they get nervous. Don't hire the wrong psychiatrist to do this, believe me, because they'll be nervous and they'll say, I have to see all the patients. They are getting information from the PCP. They're getting information from the PHQ-9, GAD-7, CD bipolar, PCL5, Vanderbilt, whatever it is you're gathering on the patients. They've got those quality metrics. They've got the assessment by, if there's someone in your clinic, your therapist, your care manager, whatever that looks like, they've got all the PCP's notes. And so they're able to, you know, really look into the EHR, see what the PCP is doing, see what the meds are, that kind of thing, coming up with a provisional diagnosis and treatment recommendations. So you have to really think before you you ask a psychiatrist to do this, you got to say to them, now look, you won't be seeing the patient. We're going to give you tons of information. We're able to do, and we're doing this with NCHP. We're in their chart. We're in there looking at their information. The behavioral health people are giving us information, maybe the PCP, and we're not seeing the patient, but we're able to give recommendations based on this, in my mind, this bunch of information coming in. It's really cool. I think you could almost do it with a chart review, but boy, do I like getting the PCP or the behavioral health person's input. So you got to be able, and I say blessed are the flexible. You need to be able to hire psychiatrists who are willing to do this, who are not so concerned about liability concerns that they say, I have to see every patient, I can't do this. So hire carefully. Those of you, you know, in your fairly qualified health centers in particular, you can't have your therapist kind of setting up more of a long-term private practice model. You need people that are willing to do brief interventions, go in and out of those exam rooms with the PCP. We know sometimes we hire the wrong person. We hire a therapist who wants to do things the traditional way, that's fine. But as with that, and hiring the right person for integrated care, also hiring the right psychiatrist to do this is super important. Okay, I promised you guys I would stop blabbing and get all of you up on screen. We've got some time to both answer questions from previous sessions and also for today. So if I could, where did Tammy go? Tammy, can you tell us a little bit about how you're using your 2 part-time psychiatrists?
Well, they're mostly direct care. We have one that comes 1 day a week, all day, and he does prefer to see the patients in person.
Mm-hmm.
He does 0 hybrid work or virtual work.
Mm-hmm.
He's a little bit inflexible, as I would say. I don't know how to say it nicely, but very rigid in his prescribing habits and the way he likes to do things.
Mm-hmm.
So, that's okay.
Would he answer a phone call or an email from a primary care provider who said, help me, I'm stuck?
I believe he definitely would. He loves teaching. That is a good thing about that psychiatrist. He does like to teach other people. So I think that would be excellent.
That's one of the attributes. So there may be some rigidity around things that are done, but the question for all of us is, will they answer a question without seeing the patient? Do they like to teach? When I'm hiring psychiatrists for this job, I'm looking for someone outgoing and flexible and loves to teach and loves to be a part of the team and, you know, just willing to answer the phone, willing to kind of put aside some of their liability concerns. Oh my gosh, I can't see this patient. I can't give you recommendations. I haven't seen them. So Tammy, it sounds like you do have someone willing to teach, willing to answer consults without seeing a patient. So that's the other stuff. That's pretty good. You've got a couple of the elements that you need. What about the other one?
The other one is very flexible. He does see virtually and also in-house. He works 2 to 3 days per week with us. And like I said, he has a large caseload, a very large caseload, and there is quite a bit of people on his waiting list to be seen by that provider. It's almost like the graph that you showed where there's a large waiting list, and what was it? I guess in 2015, it was that type of model. But we have spoke with him about perhaps being in later on as time evolves, so maybe being in a consultative role, and we hope to get him to that point. But we work in FQHC, and of course we have to have providers that are also willing to work with our psychiatrists, and it's going to take a little time, but we're going to get there.
Where are you guys, Tammy?
we're in Kinston, North Carolina. It's in the rural part of eastern North Carolina. And Steve Settle, who works with us, he's also in this call. So Steve, you might have more to add to it than what I have to say about it. But about the model. This is my first time of joining these meetings. I think he's been on here every week thus far.
I thought you had the invite, Tammy, but I made sure you got it today. But yeah, I really can't add anything to what she's already said about what we're doing with the 2 psychiatrists that we've got part-time. We've got one that really only sees patients face to face in the office and isn't very flexible, and the other one will see patients remotely, however, and I think would love to do some variant of one of these models in the future.
That's great, Stephen, because I don't know if you guys, Kinston, is that where Vivian Howard is, Tammy? Man, I didn't get there before she closed that restaurant, but I have her cookbooks. You guys don't know Vivian Howard and her cookbook and her Eastern North Carolina out of Texas, and even her television show was amazing. So it's too bad she closed the restaurant. But if you, I don't know in the Kinston, if you guys are looking at collaborative care, if you're looking at, some sort of e-consult or looking at that psychiatrist. So one of the things, Stephen, that's the psychiatrist that's so full that has a big caseload. That is the model. It's really hard to switch the patients and change up the psychiatrist. But I bet that psychiatrist has a caseload of patients who could get their refills from the PCP.
He absolutely does. He sees, and he and I've talked about this many times. He has, and feel free to chime in on this, Tammy. He has a huge number of patients that are just simple major depression, anxiety, things of that order that don't really require a psychiatrist to see, but it kind of started out that way and it's kind of stuck that way, at least so far.
And this is when you guys have to get your medical director involved to sit down at a primary care meeting and say, our psychiatrists are booked and they have a lot of patients that could come back to you. And you have to say, they've got your back. If something happens, call them. You've already said the doctor doesn't mind getting a call. If something happens, call them. They've got your back. We're all in here together, one big happy family. But in order for us to free up time, we need to unload these patients. 2 things happen. Number 1, the patients don't want to do it. Number 2, the psychiatrist likes easy patients. So you do have some obstacles. So for those of you looking for a psychiatrist, listen to what Tammy and Steve just said. If you don't do something different, if you don't prep and have a different model before that psychiatrist gets there, they will click right back into what they've already done. And I think transferring patients from psychiatry back to primary care is one of the biggest things we can do to address the psychiatric workforce shortage. If you go to the cardiologist, the neurologist, the whateverologist, they may do a few things, but they send you back to primary care for your refills. You don't stay with the specialist. We're the weirdest field where you stay with the specialist, even though I just keep refilling your 20 milligrams of Prozac for 10 years. We have to prep the patients for that change in model, and you have to hire a psychiatrist willing to do it. Now, what you've got to do, Tammy, is go back and Stephen, try to undo that, and that'll be a sticking point. Your psychiatrist kind of likes those easy patients too.
And if I may complicate things just a little bit more, what's the feeling and the current status of the idea of a PCP prescribing, say, benzodiazepines and or stimulants? Because I know there's going to be some pushback from some of those patients.
Yep, and that's what they push back on. And PCPs need to learn how to do both. If I'm giving some little old lady a 1/4 milligram of Xanax once a day to use PRN, we're not talking about a severe problem. If I got someone on 6 milligrams of clonazepam and they need to be tapered, send them to the psychiatrist for the taper. If you've got this great working relationship with the patient, use the psychiatrist to give you the taper schedule, right? So it's all about education, Stephen. And if a PCP is just going to have to treat adult ADHD, for all of you guys who say you don't have one, Kurt, Krista, Sarah, Ted, those PCPs are treating it, or the patient's just not getting assessed or evaluated, right? You have to, when you don't have it, it's when you have it, you shoot everybody off to the psychiatrist and never want them back. It's like, oh my gosh, I can't give a little bit of methylphenidate ER. And it's like, yeah, you can if I provide you with education and I back you up. If all of a sudden the dog ate the methylphenidate and gosh, the dog ate the Vyvanse before that, we got a problem, right? We got a diversion problem. Something's going on. The psychiatrist needs to back up that PCP. So Stephen, it can be done, but it has to be done with this kind of change management hat on, where your psychiatrist and the medical director get together, and then they go to the med staff. Your CEO is on board, and it becomes, we're going to do this, not do you want to do this, but we're going to do this. So for those of you looking for a psychiatrist, you set in place before they even get there. This is the process. The psychiatrist is going to review every single patient and see if they can just give the PCP recommendations and move on. The psychiatrist is going to see them 2 or 3 visits, and they're going to send them back. Or the psychiatrist is going to see them once, and they're going to send them back. Or you know what? We're going to implement collaborative care. We see that model. We're going to try to tap into a Project Echo. You know, that you guys really have a lot of forethought. And then Tammy and Stephen, you guys, if you want to try anything you heard about today, it's going to take a major change management initiative, because your PCPs have had a sweet deal, and you can't afford that sweet deal. There's too many people on the waiting list for that sweet deal. But Stephen, you hit it right on the head. Those are plenty of patients that could be transferred back.
Yes.
Patients love it, and the psychiatrists love it, and there's a waiting list.
And totally agree. And the issue that we have had, because that has been suggested and addressed at our place before, and the issue every time so far at least has been just that hard pushback from the PCPs. Oh, we don't feel comfortable with this.
Yeah.
I mean, that's.
Yeah. And you could even start with, all right, for controlled substances, we'll keep them, but for everything else, we're giving them back. I mean, I had PCPs managing long-acting antipsychotics on patients. They had been stable for 10 years, hadn't been hospitalized, on an Invega Sustenna injection once a month. And the PCPs, the nurses just, in the clinic I worked in out on an Indian reservation, the nurses just, I wrote a, 6 months worth of injections. They just came by the pharmacy, nurse gave them the injection. I didn't even see them. They were stable for so long. I didn't need to see them. What was killing them was their hypertension and diabetes and smoking. And that's, they needed the PCP for that. So there's a lot of stuff PCPs can do, but if they get used to it, if you guys that are hiring people, they get used to it, you're going to be stuck, Stephen, where you and Tammy are. Now, you guys can overcome this. You can do it, but it's going to take a major change management initiative, and it has to come almost from your board and your CEO. It has to come from the top that you are going to do it. And we're going to help you. And this is how we're going to do it. And this is how the psychiatrist is going to help do it. So that's a harder issue than what the rest of you have, which is think carefully as you're hiring a psychiatrist and bringing them on board, think really carefully about all the things we talked about today. Is there a way I can hire that person and they're not filled up, in 1 month they have a waiting list, or 2 months they have a waiting list. When they first get there, everyone's happy, lots of patients are coming in, everyone's joyful, and then they fill up and we're stuck again. Just like we're stuck trying to refer to whatever mental health you have in your community. They just get stuck all over again. So you guys have some wonderful examples. For those of you who are looking for one, what are you thinking as you hear this about what you might to do? Thank you, Sarah. What you might do differently based on what you've heard today for the folks that, as you're looking for a psychiatrist and interviewing a psychiatrist, what might you do a little differently? What intrigues you that you heard today? For Kurt and Krista and Sarah and Ted.
I mean, I think it's important for us to carve aside some time for consultation and not just for direct patient care,
Excellent.
and establish that it's going to be collaborative from the beginning.
Yeah. And the patients know it too. You got to make sure you prep the patients, the psychiatrists, and the PCPs, and that you interview accordingly. You interview and find psychiatrists who love to be teachers, who love to be part of the team, and who are willing to consult without directly seeing the patient. I love it. Okay, guys, any last question before I turn this over to Stephanie? It has been a pleasure working with you. I see Justin's on the call. It has been a pleasure doing this series. I hope it's been helpful to you, and I look forward to. I saw many of you last week at the summit in Raleigh, and I look forward to seeing you guys again. We are all in FQHCs together, right? So I'm gonna turn it over to you, Stephanie.
Oh, Tammy, did you have one last thought?
Yeah.
Go ahead.
Well, I'm sorry. I do have a question of a situation that came up yesterday. I kind of wonder about walk-in patients. I mean, I don't know if it relates to this or not, but I had a patient to walk in our clinic yesterday. There's a patient over at Family Medicine, and he had never seen me or been over here to the psychiatrist, but he was obviously in distress. I talked with him, found out he was very depressed. And I spent probably about 30 minutes with him trying to figure out what was going on. He told me he thought he was dying. And anyway, so I just kind of de-escalated the situation. I felt like it was a crisis. And then I set him up with an appointment with one of the part-time psychiatrists here, the one that actually did have room in his schedule to come back. Of course, he was happy at the end. He was not in crisis mode. He was not suicidal after that. But I was wondering about the billing for that. Like, how could I put a note in the chart when he wasn't really already on our schedule? Is there a way to go about?
Are you a licensed provider, Tammy?
Yes, I am.
I mean, you guys can bill a 90791. You can bill a 90832. You can bill stuff. That's fine as long as you meet the elements of documentation. You talk to them, you diagnose them, you did an intervention, you have a follow-up plan. You can also send that patient back to primary care to get started on an antidepressant. Primary care send them over to you. Let your family medicine doc know, hey, let's get this guy started on an antidepressant. He's willing. I mean, I've got him de-escalated. Could you please start him on something before he sees the psychiatrist in 2 weeks?
Oh, okay.
They don't have to go. It's like your PCP might be able to treat him without the psychiatrist, because he's gonna go over and see that psychiatrist and get stuck over there and never come back and take up a slot for the next 2 years. Right?
Okay.
Or, get him started, still see the psychiatrist and get the psychiatrist to bless the treatment plan or change it and send him back. Not keep the patient, forever on their caseload. And that's a perfect patient to send back. A note to the PCP, hey, we're good. Could you start him on something?
Okay. Oh, all right. Thank you.
Yeah, just keep it going. Don't let waiting for a psychiatrist stop you. And if you had a psychiatrist who could make a recommendation right then and there, the psychiatrist could actually tell the PCP what to do, what he recommended. Can't tell him what to do. We can tell him what we recommend. So, okay, Stephanie, I'm sorry, guys, to cut you off, but Stephanie's got real quickly. And Justin, I don't know if you've got anything to say, but Stephanie gets to go before you because she's got something important.
Yes. Thank you, Dr. Raney, on behalf of the Southeast MHTTC. We are so appreciative of you facilitating this series with us. For our attendees, we're grateful for your participation as well. And we would appreciate your feedback. It helps us improve the trainings that we offer. So please just take a few minutes to click on that link there. Give us your feedback. Be on the lookout for an email. I'll send a reminder with this link as well. And the link to our resource page so your colleagues can check out the presentation slides and the past recordings if they're interested in doing that. So yeah, that's it from me. Thank you all so much for attending. and reach out to us if you have questions.
Sounds good. Justin, any parting comments from the guy who made this all happen?
Part of it. I'm just so grateful for Dr. Lori Raney. Thank you so much. Stephanie with NCCHCA and all of our FQHC peeps here. I'm so grateful you took the journey to come along and learn. I want to be able to provide opportunities where we can do this more often. So if questions do come up, like reach out to any of us here. Hopefully you reach out to the association for any and all help and support, because that's what we're here to provide, and connect with good partners throughout our state and elsewhere throughout our region, like we did here today, to hopefully come up with something special. So I'm just grateful. That's all. I'm just so excited. This has been such a great development, and to see like the commitment that y'all have had to come to this. I've even been doing some health center site visits recently and hearing the personal feedback of what you all have experienced so far has been really encouraging. So I'll say thank you. I'm really excited. And that's it.
Thank you, Justin. Bye, everybody.